If you've been told your nerve test, your EMG, came back normal, but you still have burning, tingling, or pain in your hands and feet, you may not have been given the right test. Because there's a type of neuropathy that standard testing can't detect. It's called small fiber neuropathy. And in my clinic, it's the most common diagnosis I make for patients who've already been told nothing is wrong. Now, before I go deeper into what small fiber neuropathy is and why EMG misses it, I want to tell you about something that we do in our clinic that most patients have never heard of. It's called qualitative sensory testing. And it's the reason that not being able to get a skin biopsy doesn't have to be the end of the road. Here's what it does. Quantitative sensory testing measures your actual ability to feel hot, cold, vibration, sharp, dull. These aren't subjective impressions. They're measured and calibrated with instruments that give us precise numerical thresholds for each sensation. We use a biothesiometer to measure vibration perception, how strong a vibration has to be before you feel it. Measured at the ankles and toes, we use a neurosynthesome to measure thermal perception, whether you can distinguish warm from cool. We use the Weinstein monofilaments to measure light touch thresholds at standardized points across the foot. What that gives us is a complete sensory map, which fibers are working, which ones are compromised, and how severely. Large fibers, small fibers, both. And here's what makes this so important for the small fiber neuropathy conversation. Small fiber neuropathy damages the C fibers and A delta fibers that carry temperature sensation and pain. Those exact fibers, which means quantitative sensory testing can detect small fiber involvement directly by measuring whether you can feel hot or cold normally. No needle, no punch biopsy, no lab specimens sent out for weeks. The insight, however, is the same. Your small fibers are either working or they're not. And this test tells us exactly how much function they've lost and where they've lost them. So if you've been told your EMG is normal and you're wondering what to do next, and a skin biopsy isn't accessible or isn't something you want to pursue, quantitative sensory testing is a test that actually answers the question your symptoms are asking. It's not testing whether your large fibers can carry an electrical signal. It's testing what's wrong with your ability to feel the normal sensations of everyday life. Hot water, cold air, the texture of the ground under your feet. That's the information that drives treatment. And it's what we build every care plan around. With that context, let me walk you through exactly what's happening in the nervous system and why standard testing actually misses it. I specialize in neuropathy. A small fiber neuropathy is one of the most underdiagnosed conditions I see. Patients who have it often spend years with real symptoms, normal tests, and no explanation. Today, I'm going to tell you exactly what small fiber neuropathy is, why standard testing, nerve testing can't find it, and what the correct test is and what to ask for if it sounds like your situation. You'll leave this video with a specific next step. So let's talk about the experience of being dismissed. For anyone who has been told their nerve tests were normal while their hands and feet still burn, I want to start there. That experience, real symptoms, clean test, no diagnosis, is one of the most frustrating situations in medicine, and it often leads somewhere even worse. Patients are told their symptoms might be anxiety or stress or something psychological. Some are referred to psychiatry. Some stop looking. Some spend years on medications for a condition they were never correctly diagnosed with. Here's what's actually happening in most of those cases. They did get a real test, the EMG, the nerve conduction study. That's a valid and very important test, but it's designed for only one type of nerve fiber, and a small fiber neuropathy affects completely different sets of fibers. The test was right, it was just testing the wrong thing. That distinction is what the entire video is really about. By the end, you'll know exactly what to ask for. Here's the biology of why that gap actually exists. So two types of nerve fibers. Really, we're going to discuss why EMG misses one of them. Your peripheral nervous system has two main categories of nerve fiber. There's large myelinated fibers. These are the A alpha and A beta fibers. They carry touch, vibration, and proprioception signals. They're well insulated and generate strong, measurable electrical signals. Then there are other small C fibers, which are unmyelinated, and A delta fibers, which are very thinly myelinated. These carry temperature sensation and pain. The burning, the tingling, and the aching defines neuropathy for most of the patients that I see. Now, here's what EMG actually measures. A nerve conduction study passes a small electrical current through the nerve and measures how fast and how strongly the signal travels. This technique only works on large fibers. They're large enough and well insulated to produce a detectable electrical signal. Small fibers are too thin. They don't generate enough electrical current to register on standard testing. They're invisible to standard nerve conduction studies. So a clean EMG, in other words, one that's normal, tells you that the large fibers are intact. It tells you nothing about the small fibers, and by default, they may diagnose you with small fiber neuropathy. A patient with devastating small fiber damage, burning feet, constant pain, loss of temperature sensation, can have a perfectly normal EMG. Think of it this way. EMG is like a smoke detector that can only detect one type of smoke. If your fire produces another kind, the alarm doesn't go off. That doesn't mean there's no fire. It means you need a different kind of detector. Once we know EMG can't see small fiber damage, the next question is, what test can? If this is finally making the normal test real symptoms experience make sense, that's the reaction I hear every week in clinic. Hit subscribe. I put this out into a kind of clinical explanation every month for people who deserve better answers than they've been given so far. So the third section is the test that can actually find this problem. The definitive test for small fiber neuropathy is a skin biopsy. Specifically, what's measured is called an epidermal nerve fiber density, or ENFD. Here's what the procedure actually looks like. A punch biopsy, roughly the diameter of a pencil eraser, is taken from a standardized location on the skin. No stitches, local anesthetic. The whole thing takes about 10 minutes. That sample is then sent to a specialized neuropathology lab where technicians count the density of small fibers in the skin's epidermal layer. Normal density means normal fiber population. Low density means small fiber nerve damage. That's the diagnosis. Here's why this works when EMG doesn't. Small fibers extend all the way up to the epidermis, in other words, the skin. They're measurable in skin tissue when they're invisible to electrical testing. The biopsy physically counts what EMG electrically not detect. Now, let's talk about the evidence for this particular test. A retrospective study found that 88% of patients with neuropathy symptoms and normal nerve conduction studies had abnormal epidermal nerve fiber density on skin biopsy compared to 10% of healthy controls. Sensitivity runs 74 to 90% at specialized neuropathology labs, specifically reaches 95 to 97%. This is not an experimental test. It's been the standard for small fiber neuropathy diagnosis for over a decade. It's not just ordered nearly as often as it should be, though. The next question is, what actually causes small fiber neuropathy? Because the cause matters for the actual treatment. So, small fiber neuropathy, let's talk about that. The most well-known cause is diabetes and prediabetes. Metabolic dysregulation is the most common driver of small fiber neuropathy. And small fibers are among the first to be affected when blood sugar control breaks down. This is why diabetic patients can develop burning and tingling symptoms even before a standard conduction study shows any change. But diabetes is far from the only cause, and in younger patients, it's often not the cause at all. Autoimmune conditions are a major frequently missed category. Sjogren's syndrome, systemic lupus erythematosus, sarcoidosis, and celiac disease are all established causes of small fiber neuropathy. The These conditions are underdiagnosed in general, and many patients don't have the classic presentation that makes them obvious on a standard workup. An autoimmune panel run specifically because of small fiber neuropathy suspicion often identifies things that routine physicals wouldn't actually catch. One thing worth noting, Sjogren's and lupus disproportionately affect women, which aligns why small fiber neuropathy tends to be underdiagnosed in female patients who are told their symptoms are stress or anxiety. Then there are the genetic sodium channel mutations, and 10A mutations cause what are called channelopathies, an abnormal pain signaling at the genetic level. These are rare, but they're important in younger patients with no metabolic or no immune cause. Genetic testing is appropriate in those idiopathic pathologies. And that brings us to idiopathic small fiber neuropathy. No identifiable cause. This accounts for 25 to 50% of small fiber neuropathy cases. Idiopathic is not the end of the conversation. It means the cause hasn't been identified yet, not that the treatment is off the table. There's still options for symptom management and nerve support even when we can't pin down a root cause. So, what does treatment look like once you have a diagnosis? And more immediately, what to ask for? If this sounds like your situation, here is what to ask for explicitly. Ask your provider for a skin biopsy with an ENFD testing, or ask for a referral to a neuropathy specialist who performs it. Use those exact words, skin biopsy, epidermal nerve fiber density. Specificity actually matters. If an autoimmune workup hasn't been done, ask for one. The panel to request is ANA, anti-SSA, and anti-SSB for Sjogren's, and anti-DNA for lupus, ACE sarcoidosis, and tissue transglutaminema for IgA celiac disease. If metabolic causes haven't been evaluated, fasting glucose, HbA1c, and B12 are the baselines. Now, what happens after the diagnosis? When a cause is identified, that cause can often be addressed directly. Autoimmune-driven small fiber neuropathy responds to an immunotherapy. In some cases, metabolic SFN responds to blood sugar correction and nerve support protocols. Celiac-related small fiber neuropathy often stabilizes with dietary management. Idiopathic SFN has symptom management options, and there's emerging evidence for specific nerve support modalities, though I'll save that for a dedicated video. Why early diagnosis matters here is the same reason it matters across. Small fiber damage is not immediately reversible once it's progressed significantly. The earlier we identify it, the better the chance of halting the damage, and in some cases partially reversing it. If you have burning feet, tingling hands, temperature changes, or constant pain, and you've been told nerve tests are normal, you haven't been cleared. You've been given the wrong test. Small fiber neuropathy is real, it's diagnosable, and there is a path forward. Here's what I want you to take from this video. EMG tests, large fiber nerves only. Small fiber neuropathy affects C fibers and A delta fibers, fibers that are invisible to standard nerve conduction studies. The correct test is a skin biopsy with an ENFD measurement of 88% of patients with symptoms, and a normal EMG had abnormal nerve fiber counts on biopsy. Causes go well beyond diabetes, Sjogren's syndrome, lupus, sarcoidosis, genetic sodium channel mutations, and idiopathic cases with no identifiable cause all produce small fiber neuropathy. A normal nerve test is not the same as a healthy nervous system. And the next step, if this sounds like you, is to ask specifically for a skin biopsy, ENFD testing, and a referral to a neuropathy specialist. Now, you can also ask for qualitative sensory testing if you don't want to go through the skin biopsy. If you want to understand what warning signs suggest your neuropathy is advancing, including signs of small fiber nerve involvement, I did a specific video on the 7 clinical signs I look for in the clinic. Sign 5 connects directly to small fiber neuropathy. I'll link it here. And if you want the bigger picture on why neuropathy treatment so often misses what actually is driving the damage, the Why Most Treatments Fail video is the companion to this one. If you've been dismissed, if you've been told nothing is wrong, drop a comment below. I read them, and you're not alone. Subscribe if you want this level of clinical detail every month. This is exactly what I put out.